Good morning, everyone. Welcome to Unacademy, where you can crack all NEET PG exams with us, with our top educators, quality content, and have a great learning experience. So, guys, let's crack NEET PG together. A little about me. I'm Dr. Sasha Menon Remedius. I've done my MBBS from Father Muller Medical College, Mangalore, my MD in Anesthesia from Father Muller Medical College, Mangalore. I have 2 publications and 1 paper presentation in the field of anesthesiology, and I have been working and teaching in Bangalore for the past 2.5. Today's topic is MCQ on reversal agents. So I have prepared a couple of quiz topics for y'all on the topic reversal agents, which was taken for y'all prior to this, and each question will have a time gap of 1 minute, and then we shall discuss the questions. So little about Unacademy now. It's one of India's largest online learning platform, where you get plus subscription and access to unlimited live and recorded courses from India's best educators. So guys, hurry, get your subscriptions, don't delay. Let's crack this exam together. Now what will you get out of Unacademy? So there are we have our daily live classes. So we have our daily live classes. That is, so basically when you are going when you are going to a coaching class institute, you have to travel, you waste your energy, you waste your time. It's a lot of effort, right? And but what happens with these online classes is you can chat with your educator, engage in discussions. Now once you reach your class, fine, you've finished the tiring part of traveling, getting ready, blah blah blah, all that is over, and you've reached your class. Now in your class there are like some, I don't know, maybe 500 students. It's a huge hall and there are so many students sitting there, and it's a little difficult for your one educator in 1 hour's time to clear, because another educator has to come and take the next hour. It's a little difficult for the educator to clear everyone's doubts. Even if the educator is taking the whole day, he has to cover a couple of topics and he has to finish that. So he doesn't really have the time to clear everyone's doubts, right? He'll never finish his topic. But here, during the live classes in between, it's quite easy for us to clear your doubts and give you all your answers. So from the comfort of your home, wherever you are, you can just chat with us during the class. We will clear your doubts, and if we don't know, we will always get back to you and clear your doubts, okay? These are structured courses. All these are structured courses. The educators have prepared well, researched well, and prepared the courses in line with your exam syllabus so that it will help you best prepare for it. Of course, these are live tests and quizzes which help you evaluate your preparation. So we have live tests and quizzes, that like one today, that will help you all with your preparation, and as it will help you all evaluate your performance, and you can analyze yourself and get a detailed idea of how you're performing and the areas you'll need to catch up on and what you'll need to do. Of course, unlimited access. One subscription gets you access to all the live and recorded courses, and you can watch them from the comfort of any of your devices, from the comfort of your home. These are some of the top educators on our platform. Dr. Nikita Nandwani, she is a PG Center in radiology, as well as mnemonics and concept focusing on must-know topics encompassing all subjects. Dr. Mohammad Azam, Dr. Divish Mishra, Dr. Preeti Sharma are some other top educators. Now coming to the courses offered, as you can see, there are about 19 subjects on the screen, and there are various courses in each of the subjects. Now coming to anesthesia, it's awarded around 11 points in NEET PG. So is radiology, psychiatry, forensic medicine. So these are smaller topics of ophthalmology, but don't lose marks on these topics just because they're small topics. Say that I'm not going to touch them. Even during your MBBS, we don't really get posted there that much, right? It's not like we're posted there. Unlike anatomy, you're doing the whole year. Medicine, you're doing the whole year. Pathology, you're doing the whole year. So unlike that, we just get posted there like maybe 15 days or a month posting, which is really not enough because nobody really concentrates on you at that point. Nobody takes an effort to tell you what it's about and all. So you really don't know what the subject is about too. So it's a little difficult to gauge. So maybe it's a little difficult to study too, but it's very interesting. And it's very scoring because even in the exam, they will not go very much in depth because these are subjects which you have not gone in depth during your MBBS, right? So these are subjects that you can score because it will be the basic stuff that we are teaching you all will be asked. So if you'll concentrate, if you'll go back, do a little more of your studying, it will really help you all. These are some of the ongoing courses on our platform. Course on neurophysiology, GI surgery, cardiovascular thoracic surgery, respiratory system, course on the larynx, and a course on pathology. Now coming to the subscription part of it. So as you can see, there are 5 types of subscriptions on screen. I would highly recommend that you all go for the 12 and the 24 month. Now why 24 month subscription? Now why would I say that? So firstly, like we just discussed, there are like 19 subjects. It's not very easy to crack all of them, right? Come on, 19 subjects is not that easy. You cannot like do it. Honestly, 6 months is quite tough. I'm not saying it's impossible. I said it is quite tough. So it's a little tough to clear these exams in 6 months and 3 months. But it's not impossible. I'm not saying it's impossible. Of course, you all can do, definitely. I mean, but 12 months is what I would recommend you all to go for. You all can take your time, um, space it out, plan, study. After all, it's knowledge at the end of the day. You're not just doing it to clear an exam. You'll have to look at it as knowledge. You all will enjoy it. Also, like I said, these smaller subjects, you all really haven't done it during the course of your MBBS. Of course, some of you all might have been really interested. That's a different issue. But most of us never really did it. I mean, went into depth into it. So you really don't know what these subjects are about, right? So you really don't know whether you'll enjoy it. So when you take this 1 year off, that's how I realized I wanted anesthesia. So you take this 1 year off, you go through, when you're studying your subjects, you just know what you want and you don't most of the time. So it's like, oh my, I wanted medicine, but that's not what I actually want, right? So I don't want to do this for the rest of my life. I would rather do ophthalmology or anesthesia or psychiatry. So you really don't know. So it's not like you're actually dealing with the subject itself, you're just reading books, but it still does help. So I would recommend that you all take your time, go for the 12-month subscription. Also, it is more economical. Now why would it be economical is because it's a one-time subscription. So after 6 months you will have to pay again if you want to subscribe to the live, the recorded classes, or any of the quizzes, or clear your doubts. You cannot access all these classes after 6 months. So with your 1 month and 24 months, 12 months and 24 months, of course you'll have enough of time to access, clear your doubts, fall back on recorded classes, etc, etc. So use my code, as you can see at the bottom of the screen, SASHA, and avail a 10% discount when you're subscribed. So guys, hurry, subscribe. Let's start preparing together. Okay, let me help you crack anesthesia in NEET PG. Now again, your 24-month subscription, kindly use my code, as you can see at the bottom of the screen in red, SASHA. Avail your 10% discount. Guys, hurry please and do subscribe quickly. So now we'll move on to today's topic, that is your quiz. So I'm going to set the timer. Okay, we're set with the timer. And 1 minute per question we will discuss. And the thing is, I have framed the questions in such a way it might look like true false, but actually I have framed the answers are with something that we can discuss, something that we can go over, so that it will be beneficial for y'all. Okay, so the first question is, time all are true about anticholinesterases except. Your time starts now. Inhibits the action of acetylcholinesterase at the neuromuscular junction, prolongs the half-life of acetylcholine and potentiating its effect, especially in the presence of residual amounts of muscle relaxants at the end of surgery. The primary clinical use of cholinesterase inhibitors also called anticholinesterases, is to reverse depolarizing muscle blockade, and some of these agents are also used to diagnose and treat myasthenia gravis. Okay, your time is up, and the answer is, so your answer is actually number 3. Okay. The primary clinical use of cholinesterase inhibitors, also called anticholinesterase. So anticholinesterase are also known as cholinesterase inhibitors. Okay. So your cholinesterase inhibitors or anticholinesterase are also is used to reverse. Primary clinical use is non-depolarizing. To reverse non-depolarizing muscle blockade, depolarizing drug is basically a succinyl choline, which is cleared by your plasma cholinesterase in the plasma. There is no, so it is cleared by plasma cholinesterase. Succinyl choline is your depolarizing muscle relaxant. So acetylcholinesterase like neostigmine, pyridostigmine, physostigmine is basically used to reverse non-depolarizing muscle blockade. Now, it inhibits the action of acetylcholinesterase at the neuromuscular junction. Yes, acetylcholinesterase is the enzyme which degrades acetylcholine at the neuromuscular junction. So, this anticholinesterase will degrade this enzyme, which will lead to the increase in acetylcholine at the neuromuscular junction, which will compete with non-depolarizing muscle relaxant to reverse the blockade. And this will reverse your blockade. Okay, it prolongs the half-life of acetylcholine and potentiates its effects. Yeah, so it prolongs the half-life of acetylcholine by degrading acetylcholinesterase enzyme, especially when there is, so it potentiates its effects, especially in the presence of residual amount of neuromuscular relaxant. So it basically competes with the non-depolarizing muscle relaxant. Some of these agents are also used to diagnose and treat myasthenia gravis. Your next question, goals of reversal of neuromuscular blockade are all except, your time starts now. Primary goal is to maximize muscarinic transmission with the minimum of nicotinic side effects. Reversal of blockade should be spontaneous redistribution, metabolism, excretion from the body, pharmacological reversal. Cholinesterase inhibitors indirectly increase the amount of acetylcholine available to compete with the non-depolarizing agent, and there should be complete reversal of effects. Read your questions carefully. Yeah, so the answer is number 1. Primary goal is to maximize nicotinic transmission with a minimum of muscarinic side effects. Yeah. So the primary goal is to maximize nicotinic transmission because the transmission at the neuromuscular junction is nicotinic transmission. So it maximizes nicotinic transmission with the minimum muscarinic effects. So there should be reversal of blockade. There should be a spontaneous reversal. There should be redistribution, metabolism, excretion from the body, and pharmacological reversal. All should be possible for a reversal of a muscle relaxant. Cholinesterase inhibitors indirectly increase the amount of acetylcholine available to compete with non-depolarizing agent. We discussed that in the previous question, and there should be complete reversal of effects. Your next question. Cholinesterase inhibitors can act at cholinergic receptors of several other organ systems, causing all except bradycardia, nausea, vomiting, fecal incontinence, and bronchodilation. So, cholinesterase inhibitors can act at the cholinergic receptors and cause all the following except yes, your answer is bronchodilation, right? So, bradycardia, nausea, vomiting, fecal incontinence are all cholinergic effects. By action at the muscarinic receptors. So it doesn't cause bronchodilation, it actually causes bronchoconstriction. Cholinesterase inhibitor that crosses the blood-brain barrier is neostigmine, physostigmine, pyridostigmine, atropine. Because it crosses the blood-brain barrier, it is not used for pharmacological reversal of non-depolarizing muscle relaxant. Okay, so your answer is number 2, physostigmine, which crosses the blood-brain barrier. Neostigmine, pyridostigmine, hydrophonium do not cross. Neostigmine is a reversal agent of choice. Hydrophonium is short-acting. Pyridostigmine is long-acting. This crosses blood-brain. Muscarinic actions are all except increase of sweat and saliva, bronchoconstriction, increase peristalsis, mydriasis. The answer is number, oops, I'm sorry. Answer is number 4, mydriasis. Okay. Now again, muscarinic actions are increase in sweat and saliva. So there is sweating and salivation. Bronchoconstriction, increased peristalsis which leads to diarrhea, urinary incontinence, and of course instead of mydriasis it is actually meiosis. There will be meiosis, not mydriasis. All are true about when a reversal agent should be given, except no amount of cholinesterase inhibitor can immediately reverse a block that is so intense that there is no response to tetanic peripheral nerve stimulation. Moreover, absence of any palpable single twitches following 5 seconds of tetanic stimulation at 50 Hz implies a very intense blockade that cannot be reversed. Some evidence of spontaneous recovery, that is 2 to 3 twitches of the train of 4, should be present before reversal is attempted. The single twitch count generally correlates with the time of return of the first twitch of the 4 before the return of the first twitch of the 4 of train of 4, and therefore the availability to reverse intense paralysis. Your answer is, oh my God, number 4. So it's not the single twitch count actually. It is your post-tetanic So your post-tetanic potentiation generally correlates with the time of return of the first twitch of the train of 4, and therefore the ability to reverse the intense paralysis. So generally a post-tetanic potentiation of 3. So after a tetanic stimulus, there will be a post-tetanic potentiation of 3, generally correlates with the TOF of 1. So this correlates with the time of return of first twitch of the TOF and the ability to reverse intense paralysis. That means paralysis is recovering. This TOF 1 means paralysis is recovering and patient can be reversed. So no amount of cholinesterase inhibitor can immediately reverse a block that is so intense that there is no response to tetanic peripheral nerve stimulation. The tetanic nerve stimulation is a 50 Hz impulse, and if there is no response to this, that means that the block is an intense block, a very deep block, and however much of cholinesterase inhibitor is given, it cannot immediately reverse the block. The absence of any palpable single twitches following this tetanic stimulation, a very intense blockade that indicates a very intense blockade cannot be reversed, like the previous point. Here also, when there is absence of any stimulation, when there is any absence The stimulation produced by tetanic count, it indicates that it is a very intense blockade and that cannot be reversed. So some evidence of spontaneous recovery, that is 2 to 3 twitch on the train of force, should be present before a reversal is attempted. This is to prevent uh, delayed recovery and post-op complications that are associated with uh, residual neuromuscular paralysis. All the following factors influence when a reversal agent should be given, except choice of cholinesterase administered, dose of cholinesterase inhibitor administered, the muscle relaxant being antagonized, and extent of the blockade before reversal. So your answer is choice of colon. It's not the choice of cholinesterase that matters. It is basically choice of anticholinesterase that will matter. The choice of cholinesterase does not matter. Choice of anticholinesterase administered, the dose of cholinesterase inhibitor administered, the muscle relaxant that is being antagonized, that is short acting, intermediate or long, okay, and the extent of the blockade before reversal. So a very deep block, reversal agent will have no effect, so it should not be given. So a minimum of 2 to 3 train of force should be present before reversal of blockade is attempted. Next question. All are true about neostigmine except, your time starts now. Physical structure consists of a carbamate moiety, provides non-covalent bonding to acetylcholinesterase. Quaternary ammonium group renders a molecule lipid insoluble so that it cannot pass through the blood-brain barrier. Dosage is 0.04 to 0.08 mg per kg in combination with either atropine 0.02 mg per kg or glycopyrrolate 0.01 mg per kg. Neostigmine takes at least 2 minutes to initial effect and recovery. Okay, your time is up and your answer is number 1. Yet again. The physical structure consists of a carbamate moiety, yes, and provides covalent bonding to the acetylcholinesterase. So neostigmine binds covalently with acetylcholinesterase enzyme and degrades the enzyme. Okay, so that it binds covalently, not non-covalent. Non-covalently means it can diffuse away, so it is a permanent bond, covalent bonding, and degrades the enzyme. The quaternary ammonium group that is there on neostigmine renders the molecule lipid insoluble so that it cannot pass through the blood-brain barrier. So there is no passage of blood through the blood-brain barrier. The dosage, yes, is of course 0.04 to 0.08 milligram per kg, and it is given with atropine or glycopyrrolate to counteract the muscarinic effects. So it's basically given with these drugs to counteract the muscarinic effects. Neostigmine takes at least 2 minutes to have an initial effect. All are true about hydrophonium except hydrophonium is less than 10% as potent as neostigmine. The drug competes with acetylcholine and binds by non-covalent bonding to acetylcholinesterase at the anionic site. Onset time is 1 to 2 minutes, peak effect 0.8 to 0.2 minute, duration of action 10 minutes. Although glycopyrrolate can also be used, it should be given to reverse the effects, it should be given along with hydrophonium. See, okay, your answer is number 4. So, glycopyrrolate and atropine are used to counteract the muscarinic effects of these anticholinesterase drugs. Now, the onset of action of neostigmine is, as you can see, the onset is 1 to 2 minutes. Okay, hydrophonium, so I'm sorry, the of hydrophonium is 1 to 2 minutes. Sorry, just a sec. Okay, so the onset of action of hydrophonium, as you can see, is 1 to 2 minutes, and neostigmine is around 2 to 3 minutes. That is your onset of action. So now glycopyrrolate onset of action is approximately 2 minutes. Whereas atropine onset of action is 1 to 2 minutes. So glycopyrrolate cannot be given with hydrophonium. It should ideally be given 2 minutes before hydrophonium, so that when hydrophonium is given, there are no side effects are produced. So glycopyrrolate ideally should be given prior to administering hydrophonium. If you're using an anticholinergic, you would use atropine with hydrophonium because they have similar times of onset of reaction and similar recoveries. As a result, the patient will be comfortable till the end and the side effects will be counteracted till the end. Now your hydrophonium is less than 10% as potent as neostigmine. Yes, important point. And the drug competes with acetylcholine and binds by a non-covalent bond to acetylcholinesterase at the anionic site. So at the anionic site, it binds with the by non-covalent bond. So what happens is, it's a non-covalent bond, so it diffuses away from the enzyme, and as a result there will be reversal of action. So it is short acting. Okay, reversal of action of hydrophonium. It is short acting. It does not bind covalently. It binds by a non-covalent bond, so it diffuses away from the site of action and the mechanism of action will be reversed. The onset time is 1 to 2 minutes and peak effect occurs in 0.8 to 2 minute duration, and the duration of action is 10 minutes. All are true regarding reversal of at the neuromuscular junction and reversal agents, except the time needed to reach a TOF count of 0.9 after reversal administration is shorter when a higher TOF count is present at reversal. If 4 responses to TOF nerve are present, approximately 15 minutes are needed to reach a ratio of 0.9. Anticholinesterases should be given 15 to 30 minutes before removal of endotracheal tube. Large doses of anticholinesterase result in more rapid and complete reversal of blockade. Doses can be increased continually till reversal is achieved. This is an important MCQ. Yes. So your answer is number 4. Okay. Answer is so sorry. Answer is number 4. So larger of doses of anticholinesterase will result in more rapid and complete reversal. Doses cannot be increased beyond maximum dose of anticholinesterase. This is a ceiling effect. Write it here. This is known as a ceiling effect, C-E-I-L-I-N-G, ceiling effect. This is basically as acetylcholine esterase is degraded, acetylcholine goes on increasing, acetylcholine goes on increasing at the neuromuscular junction. So as acetylcholine is increasing, there is some reuptake and some redistribution. Okay, so once this reuptake and redistribution reach equilibrium, okay, and once the anticholinesterase, the acetylcholinesterase has been maximally inhibited, there will no more of the drug of the anticholinesterase will be able to increase acetylcholine at the neuromuscular junction. So the reuptake and redistribution will reach an equilibrium. So as acetylcholine goes on accumulating at the neuromuscular junction, there is reuptake of acetylcholine as well as redistribution of acetylcholine. This reuptake and redistribution will reach an equilibrium. When this equilibrium is reached, by then the enzyme acetylcholinesterase would be maximally be inhibited by the anticholinesterase. So the enzyme would be saturated, inhibited completely. So no amount of larger doses, you cannot increase beyond that. Increasing the anticholinesterase dose will have no effect. That is because the ceiling effect of the drug has reached. Basically, the reuptake and redistribution of acetylcholine has been equalized, right? So there will be no further reversal occurring, no speed up of reversal. But initially, yes, large doses can result in more rapid and complete reversal. So the time needed to reach a train of 4 count of 0.9 after reversal administration is shorter when a higher TOF count is present at reversal. So now your train of 4 count is basically your fourth twitch to your first twitch, right? So after paralysis, basically as the muscle is recovering, you will see so after paralysis you will get, when a nerve is stimulated, you will get this will be your train of 4, basically a decreasing order, right? So this will be your decreasing order. So when your T4 by T1 is, suppose I say it is 0.5 at reversal versus a T4 by T1, that is when the surgical case is over, when you stimulate the nerve to check your T4 by T1 TOF ratio is 0.2, So to point 9 is the endpoint where there will be complete recovery of neuromuscular junction in most subjects, right? So when the reversal agent, when anticholinesterase is administered when the TOF is 0.5, to reach a TOF count of 0.9, the time required will be shorter as compared to when the reversal agent is given when the TOF is 0.2. So when the TOF ratio is 0.2, more time will be required to reach a TOF ratio of 0.9 before the endotracheal tube can be removed. So if 4 responses to TOF nerve are present, approximately 15 minutes is needed to reach a ratio of 0.9. So that is a midpoint, so you can calculate plus or minus like that. Anticholinesterases should be given 15 to 30 minutes before removal of endotracheal tube. So generally when the TOF count is 4 or 5, generally this anti-reversal agent will be given, the anticholinesterase will be given, and following that about 15 to 30 minutes will be needed, because generally a TOF count of 0.4 is needed before a reversal is given. So 15 to 30, 2 to 3 is needed. So around 15 to 30 minutes will be needed before removal of endotracheal tube. Most of the times in the operation theatre, the reversal agent is given and the tube is removed immediately because we feel that the patient is breathing well, which is actually wrong. So it should be given 15 to 30 minutes prior to when you anticipate you will require to remove the tube, depending of course on the muscle relaxant use, the dose of the anticholinesterase, when you need to give, when was the last dose of the muscle relaxant use. So depending on all that, you can estimate the time at which the endotracheal tube might be removed, and 15 to 30 minutes prior to getting that, the anticholinesterase should be given. Regarding type and dose of anticholinesterase, all are true except larger doses result in more rapid and complete reversal of blockade until maximum dose of anticholinesterase is given. Reversal of blockade differs between adults and children. Duration of action is prolonged in older patients and resulting in a decreased risk of recurrization. Respiratory acidosis and metabolic alkalosis, the dose of neostigmine is nearly doubled to produce a comparable recovery. Okay, your time is up. So your answer is number 2. Reversal of blockade does not differ between adults and children. Okay, it does not differ, that is, no dose adjustment is needed. Now, larger doses result in more rapid and complete reversal of blockade until maximal dose of anticholinesterase is given. This is basically your C-link effect, what we discussed. Okay, reversal of blockade does not differ between adults and children. The duration of action is prolonged in older patients and there is decreased risk of recurrization. So what happens in older patients? Basically your hepatic and renal blood flow is decreased. So your hepatic and renal blood flow is decreased in older patients. So the clearances of these drugs will be decreased. As a result, they will have a prolonged duration of action. But when this happens, when in older patients hepatic and renal blood flow decrease, as a result, the clearance of muscle relaxants of non-depolarizing, since they depend on the liver and the kidney for clearance, for metabolism. So the metabolism of non-depolarizing muscle relaxants is also increased. So this prevents recurrization. So recurrization is basically when uh, when when the action of the anticholinesterase is shorter than that of the neuromuscular blocking drug. So the anticholinesterase action gets terminated, and the neuromuscular blocking drug action still persists. There will be some residual weakness known as recurverization. But when there is in older patients, the hepatic and renal blood flow is decreased because of decreased cardiac output. So in these patients, anyways, a non-depolarizing muscle relaxant's duration of action will be prolonged. Side by side, the anticholinesterases duration also will be prolonged. As a result, there will be no change in effect. There will be no recurverization occurring. Your respiratory acidosis and metabolic alkalosis, the dose of neostigmine has to be doubled to produce a comparative recovery. All are true about cardiovascular effects produced by anticholinesterases except pronounced vagal effects, bradycardia, bradyarrhythmias. In order to counteract these effects, atropine and glycopyrrolate are given. Parasympathetic control of heart rate is less impaired with glycopyrrolate. The onset of cholinergic effect of neostigmine corresponds with the onset of cholinergic effect of atropine. Okay. So the answer is pronounced vagal effects. The answer is number 4. Number 4. So the onset of cholinergic effect of neostigmine corresponds with the anticholinergic effect of glycopyrrolate, like we discussed. So it corresponds with glycopyrrolate. Neostigmine onset of action is 2 minutes. So is glycopyrrolate, and they have a similar duration of action. So neostigmine is generally given with glycopyrrolate. Now the cardiovascular effects are it produces vagal effects like bradycardia, bradyarrhythmias. In order to counteract these effects, that is why atropine and glycopyrrolate are given, and also to counteract the increased salivation and secretion effects. Parasympathetic control of the heart rate is less impaired with glycopyrrolate than with atropine. Atropine also crosses blood-brain barrier. We prefer not to use drugs which cross the blood-brain barrier. All are true about Sugama-Dex except reversal occurs at all levels of neuromuscular blockade. It is a modified delta cyclodextrin. Su refers to sugar, gamma-dex refers to the structural molecule cyclodextrin. So gamma-dex is a normal selective relaxin binding agent that is currently available for clinical use in Europe. Okay, so your answer is modified. This is a modified gamma dex, right? Cyclodex. So basically, it is an oligosaccharide that is made up of, this is that gamma cyclodextrin is an 8-chain oligosaccharide. Okay? So 8-chain oligosaccharide is your gamma cyclodextrin. So it reversal occurs at all levels of neuromuscular blockade. So gamma dex is used for rocuronium and vecuronium reversal. So basically for rocuronium and vecuronium reversal. So gamma dex is used. So it occurs at all levels of neuromuscular blockade. It is a modified gamma cyclodextrin, basically a chain oligosaccharide. Su refers to sugar and gamma dex refers to the structural molecule gamma cyclodextrin. It is donut shaped. It's basically a donut shaped, and it's donut shaped, and it is a novel. It is a selective relaxin binding agent that is currently available for use in Europe. All are true about the mechanism of action of Sugama Dex except hydrophobic interactions trap the drug like rocuronium in the cyclodextrin cavity, resulting in the tight formation of a water-soluble guest-host complex in a ratio of 2:1. It terminates the neuromuscular blocking actions and restrains the drug in the extracellular fluid where it cannot interact with nicotinic acetylcholine receptors. It is eliminated unchanged via the kidneys. Three-dimensional structure resembles a hollow truncated cone or donut with a hydrophobic cavity and a hydrophilic exterior. Okay, so your answer is number one. So basically, it forms a water-soluble guest-host complex in a ratio of 1:1. One rocuronium, one gamma dex molecule for one rocuronium. So basically, it is a three-dimensional structure, number fourth point, which resembles a cone or a donut. So this is your donut, this is your Sugama Dex complex, these are the side chains, okay? And it has a hydrophobic cavity. This is hydrophobic, and it has a hydrophilic exterior. So it has a hydrophobic cavity and a hydrophilic exterior. Now basically what happens is the hydrophobic interaction that trap the drug rocuronium in the cavity. So in the donut hole, rocuronium gets trapped, resulting in the entire complex becomes a water soluble guest host agent. Guest host complex. Okay, so the entire thing becomes a guest host complex and the action gets terminated. So this terminates the neuromuscular blocking action and restrains the drug in the intracellular fluid where it cannot interact with the nicotinic acetylcholine receptor. So because it is trapped in this water soluble guest host complex, it cannot interact with the nicotinic acetylcholine receptor. So gamma dex is excreted unchanged in kidney. There is no metabolism, large molecule excreted unchanged in kidney. Hence, as such, there is no dose adjustments needed. Then the three-dimensional structure, this we discussed, resembles a cone, hollow truncated cone or donut with a your hydrophobic cavity and your hydrophilic exterior. All are true about Sugama Dex except due to hypersensitivity and allergic reaction, Sugama Dex has not yet been approved by the US Food and Drug Administration. Hepatic excretion is the primary route of elimination for rocuronium Sugama Dex complex. Hemodialysis is an effective way of removing this complex in renal impairment. Reversal of large doses of rocuronium with 16 mg per kg of Sugama-dex. So your answer is this. So after it forms a water soluble guest host complex, this entire complex, this entire thing is excreted via the kidney. So it's not the liver, basically the kidneys. So now actually rocuronium, if you remember, the method of elimination is hepatic and bile. Okay? Whereas Sugama-dex, the method of elimination is metabolism is basically it is excreted unchanged by the kidney. So when it forms this water soluble guest host complex, it is eliminated by the kidney. So due to hypersensitivity and allergic reaction, Sugama-dex is not yet approved by the FDA, the US Food and Drug Administration. It is in Europe. So in kidney failure, it has been found that because this is a very large molecule, it has been found that hemodialysis is an effective way of removing this complex, right? So in kidney failure, when the kidneys are not functioning to eliminate this water soluble guest host complex, hemodialysis has been found to be a good and effective method. Now, reversal of large doses of rocuronium is possible with 16 mg per kg of Sugama-dex. So when an intubating dose of rocuronium, that is 1.2 mg per kg, is used, that is an intubating dose, and if reversal is desired immediately, as the patient needs to be brought out immediately, suppose you can't intubate or something, large dose of rocuronium is given, you cannot wait any longer, 16 mg of per kg of Sugama-dex can be given, and within 1 to 2 minutes the patient will be awake and breathing. Reversal occurs. All are true about L-cysteine except, so it is an endogenous amino acid that is often added to total parenteral nutrition regimes to enhance calcium and phosphate solubility, reverses the neuromuscular blocking effects of ganticurium and other fumarates. Ganticurium and other fumarates rapidly combine with L-cysteine in vitro to form active degradation products, which are which are known as adducts. This is formed by adduction of cysteine to the double bonds of the compound. L-cysteine is, when given to anesthetized monkeys, 1 minute after these 1 minute after neuromuscular blocking agents are given, the block can be abolished in 2 to 3 minutes. Sorry. Okay, time is up, and the answer is number 3. They do not form active degradation products, they form inactive degradation products. Okay, not active, it is inactive. These adducts which are the degradation products are actually inactive. So L-cysteine is an endogenous amino acid, yes, added to TPN to enhance calcium and phosphate solubility. Yes, it is true. It reverses the neuromuscular blocking effects of ganticurium and other fumarates. These are newer acting neuromuscular blocking drugs, short acting. Ganticurium and other fumarates combine with L-cysteine to form inactive degradation products known as adducts. These are formed by adduction of cysteine to the double bonds of the fumarates and ganticurium. So cysteine forms adducts to the ganticurium and fumarate molecules, forming an inactive degradation product. This entire product is known as adducts, which is excreted. So Lcysteine, 10 to 50 mg per kg IV, which it has not been tried in humans yet. It is still needed for approval. So 10 to 50 milligram per kg when it is given to anesthetized monkeys. 1 minute after the neuromuscular blocking drug is given, the block can be abolished within 2 to 3 minutes. This is your last question for the day for today. Residual postoperative neuromuscular blockade, all are true except increased chemoreceptor sensitivity to hypoxia, impairment of pharyngeal and esophageal muscles, impaired ability to maintain an open upper airway, pulmonary complications. This is the effects of inadequate reversal, residual postoperative neuromuscular blockade, all are true except, so this residual effect of inadequate reversal. Okay, time's up. The answer is number 1. So residual postoperative neuromuscular blockade, which occurs due to inadequate reversal, all are true except, so there is decreased chemoreceptor sensitivity to hypoxia, which is very dangerous, as a hypoxic drive is abolished of the patient. There is impairment of pharyngeal and esophageal muscles, which can lead to aspiration. There is inability to maintain the upper way, which again can lead to aspiration. The pharyngeal and laryngeal, the pharyngeal muscles are lax, so there will be collapse, and this can lead to collapse of the airway. That is basically aspiration, as well as patient cannot breathe because there is collapse of the upper airway, and all this due to aspiration can lead to pulmonary complications. So there is decreased chemoreceptor sensitivity to hypoxia. So that's it guys today. This was the quiz on reversal agents, and tomorrow will be my class on continual. I will be continuing my topic, that regional anesthesia, 7:30 p.m. tomorrow. Do study well and have a good day. I will see you all tomorrow, and don't forget to use my code SASHA and get your attractive 10% discount on your subscription. Guys, all the best, do well. I shall see you soon. Thank you.